healthcare industry is going to change dramatically in the next couple of years.
To chronic disease management and the preventative aspect of care.
AI can now understand the key clinical concepts of what's being verbalized in healthcare.
Welcome to Leaders in Healthcare. I'm Dr. Jordan Vollrath, physician, entrepreneur, and Chief Medical Officer for Cherry Health. We're talking about all things healthcare. Join us as we speak to innovators, industry leaders, and the people working to drive the healthcare system forward. Today we're talking to Tanya Mamtazian. She's a registered midwife working and living in Nelson, BC, the unceded territories of the Ktunaxa, Kainai, and Syilx nations. In 2007, she was one of the first graduates from the UBC midwifery program at the Department of Family Practice at the Faculty of Medicine. Tanya has a Master's of Public Health from Johns Hopkins University and recently completed her Canadian Health Executive Certificate. She's worked as a midwife in Nelson for 17 years and 10 years ago co-created Apple Tree Maternity, the first rural collaborative maternity practice with midwives, family physicians, RNs, and other allied health. Tanya grew up in Calgary to a mother of mixed ethnicity from Trinidad and Tobago and a father with English and Irish ancestry. She's married to a Persian man, a Baha'i refugee from Iran, and has two tweens who are growing like weeds. Tanya's day job includes catching babies, running a busy maternity clinic, and precepting and teaching midwifery students. She is also the chair of the board of the BC College of Nurses and Midwives. The focus of this conversation will be talking about the BCCNM and the role of health regulation in the system. Tanya, thanks so much for joining us.
Hi, thank you.
How did you get into the administrative side of healthcare? You're a practitioner, you clearly enjoy what you do and seeing patients, catching babies. How did you actually start making the transition over towards the behind the scenes?
Yeah, midwifery is still a very small profession. So in BC, there are over 500 midwives, just 400 practicing. And when I started, there were even fewer. And so really, with midwifery, because it's such a small profession, there's an expectation once you have your clinical skills down pat to actually be involved in the health system in some manner or other if you have capacity and interest, which I did. So I just kind of fell into the college before it amalgamated with the nurses. We were the College of Midwives of BC. So I've been in health regulation for about 10 years, and I just happened to join it and then join the board, and I've loved health regulation ever since. I find it fascinating.
Oh, that's awesome. How did it go with the amalgamation of the two? I mean, the nurses' college is probably one of the bigger ones in the entire province just by number of people under their umbrella versus coming from one with only a few hundred. That must have been quite the transition.
Yeah, it was honestly, it was daunting at first. So there are many changes happening within the BC health regulation system, and they're calling it modernizing healthcare, which includes a number of amalgamations. And so now BC has 6 health regulatory colleges versus previously 21. So we were the smallest college, and so we knew we were going to have to amalgamate. It was going to be mandated, and we decided to be a little bit more proactive about it and not wait for the mandate. And so we did actually have the choice between the nursing professionals and the College of Physicians and Surgeons, and they were both excellent options. They both really focus on public protection and public safety, which of course is our job within the college. The nursing professionals, they regulate nurse practitioners as well, and with nursing professionals, they also have registered nurses and licensed practical nurses, LPN. So they had recently gone through an amalgamation of the four nursing designations, and nurse practitioners and midwives are also primary care providers. So it seemed like a good fit, and also the nurses are very future focused in terms of really looking at health regulation in the future. So we went with the nurses, and how it was structured with the board is that we have a board of 10, 5 of which are professional board members, and each profession has a designation. So even though there's over 48,000 registered nurses and now 500 midwives, we all have a professional designation on the board, and then there's 5 public members. So it's actually been great. Of course, there's learning challenges along the way and growth. But we really do see the benefit of having the resources available to us of such a large organization.
Definitely, definitely. Well, and then backing up, just for anybody who's not really aware of how the landscape in healthcare typically works, could you outline kind of the role of the college and sort of perhaps how that's different from the association of nurses or midwives?
Yeah, so the college, so any health regulatory college, its primary focus is to protect the public, whereas the professional associations are there to support, help, advocate, sometimes negotiate for the profession. So protecting the public, it does so in a number of ways. One, it registers professionals, and so in order to register as a health professional, you have to demonstrate that you've met some educational competencies. Two, it recognizes educational institutions. And so there's a number of processes and so on, but in order to be registered, the education institution has to be recognized or programmed. Three, it sets standards of practice. And so these are usually fairly broad standards of practice, but very specific to health professionals in terms of how we would expect a health professional to behave and act. And then there's an accountability mechanism of inquiry and discipline if there's a complaint or a report that those standards of practice have been breached. Then there's an inquiry and a mechanism to look at that. And if there was found to be some fault or challenges, then some kind of accountability mechanism. And then there's also quality assurance arm or process of it. So rather than waiting for people to go to the inquiry complaints, being a little bit proactive and trying to, educate people on what the standards are, how does that actually look in practice? How can we continuously improve and evolve to provide the best quality of care?
And so you guys are the gatekeepers then to the title of nurse and midwife. So I think those are protected terms, like legally speaking. Like somebody out there cannot call themselves a nurse or a midwife unless they've been sanctioned through the college. Is that correct?
That's absolutely correct. Yes, you cannot call yourself a nurse or a midwife. And we actually had a case probably about 6 or 7 years ago where there was someone calling themselves a death midwife. And so they supported people through the dying phase of life. And there's a lot of death doulas. Doulas are different from midwives and they are not regulated. But the death midwife, it can cause confusion when, someone who's unregulated is calling themselves a professional designation, because that means that, we have all these rules and standards and we have a college that enforces them when we're using this title. So we did have to take it to court, and we actually had to take it to the Supreme Court, and that was reinforced that the professional titles should be protected.
Around here, like every once in a while, I'll run into like the lawn doctor landscaping company's branding, and I'll think to myself, like, oh, that's a no-no. You're not allowed to do that.
That's right. You're not. And like those, we even talked about that when we were discussing whether to follow up on the death midwife, especially with death, like there's some connotation to healthcare as well. And so we felt that we're doing our due diligence to follow through.
What do you guys actually wind up doing with most of your time or most of the resources that come through the organization? Is it following up on complaints or dealing with the educational side? Or is it fair to say that there is one main function that takes up more time and energy than the others?
Well, inquiry and discipline takes up a significant portion of the college's work, a significant portion of our resources, mostly because there's a lot of lawyers involved and they can be quite expensive. But the complexity of complaints that are coming in are significant. The acuity and the number of complaints are increasing. And also at this time, we're really kind of looking at, our approach to complaints and discipline in general. it's right now it's very much a justice approach, like you did something harmful and then you are going to pay for it. And then but in the real life, things are a little bit different. And often, of course, for the very egregious circumstances, like there needs to be very strong accountability, which can go to losing your license or, having it revoked for a period of time. That's really rarely the case that happens, though. For the other cases, it's often, it often has some learning and growth to it, and just not really recognizing kind of the unprofessional behavior or the inappropriate behavior that was given. And so, it's trying to figure out how we can regulate and discuss these complaints or reports of care to these health professionals without us looking like the police and that we're going to throw them in jail. And also, the public needs to feel safe when they access healthcare, and they need to feel that they're going to get the best quality of care. And if they don't, they have an avenue to report that. And it's not just the public like you and me and our friends and family. It's the whole public that we serve. So there's a big focus, strategic focus with the BC College of Nurses and Midwives on Indigenous-Specific anti-racism and Indigenous people specifically not feeling safe in accessing the healthcare and, receiving poor care when they do at times.
So let's follow up on that. But first, maybe could you give us a bit of an overview of how the complaints and the resolution process works? I've been being a good boy. I have yet to get in trouble, knock on wood. So I'm not 100% familiar with how this actually plays out in the medical profession either. How does it actually go?
Yeah, and I don't have a lot to do with complaints, so I will do my best, but bear with me if I make mistakes. So first of all, if there's a complaint, so you are concerned that a standard wasn't met, either the public can directly make a complaint to the college, or sometimes the health authority will make a complaint to the college. And there is actually more closer relationships with health authorities these days to really determine when it's appropriate for the college to step in versus whether it's appropriate for the employers to step in. For nurses, it's different for midwives and for physicians. And then sometimes other professionals, like we have a duty to report. So if you see a physician who is clearly practicing outside of standards, then it's actually our duty to self-report. Then it goes to the college, and then there's the registrar stream. So those streams are more specific, related to kind of mental health challenges, substance use, capacity challenges, more health related challenges. And then there's a committee stream that is more related to, clinical competencies or professional standards, professionalism, and so on. So the registrar stream is usually managed in-house with staff, and there's a process and there's a discussion. Then often there's an agreement that is made in terms of steps moving forward. In the committee stream, then a committee with two professionals, usually two professionals of your own designation, and a public member. And then there's also support staff, and usually a lawyer support staff who looks at the actual complaint and then makes a recommendation based on that. Usually it can come to a consent agreement. If not, or the very egregious circumstances, will go to discipline. And discipline is very separate from the complaints process, and it's almost a quasi-judicial process. And actually, our discipline, it doesn't happen very often, basically. And our disciplinary process is slowly getting taken away from the health regulatory colleges in BC. And there's going to be a separate superintendent of health. I think it's superintendent of health regulation, but they're going to manage the discipline process to make it even considered more fair, just, and equitable. But the vast majority of healthcare providers will never have to go through that process. And we are trying to make it as, not easy, but as straightforward and supportive as possible, both for the public and for the health professionals, because we need health professionals working in the system to get that.
Well, it's got to be fair, right? It can't just be, okay, well, there's a shortage of health professionals, so they get away with anything, right? It's got to be sort of that due process. So that makes a ton of sense.
Yeah, but it can be long and arduous, and it can get very expensive. And that is part of the challenge, is that, our organization is run by fees that we charge to our registrants. Sorry, I'm just going to mute that. And so, it's quite expensive to do this properly and give due process and so on. And so, unfortunately, it's the registrants who end up having to pay for it.
A little bit ironic, I suppose. How common are complaints? If your college is about 70,000 members deep, how many complaints roughly do actually come through the doors in a year?
Ooh, I actually don't know. I don't have the numbers off the top of my head, but hundreds, and it is increasing as people understand more the role of the College of Nurses and Midwives, but also the College of Physicians and Surgeons and all the other health regulatory colleges. We are getting more and more complaints, and every complaint needs a due process and to really look at it.
This show is brought to you by Cherry Health, Canada's medical network where healthcare practitioners connect. Physicians, pharmacists, nurses, chiropractors, and all other healthcare professionals can sign up for free, start connecting, messaging with colleagues, or checking out job opportunities posted by thousands of employers across Canada. With dozens of healthcare-specific job filters and search options, we make it easy to advance your career, find your dream job, or line up your next locum with hundreds of new jobs posted every week. www.cherry.health to get connected today. And then circling back around to your point earlier of, it's been recognized that Indigenous people have been having a challenging time accessing the system or following up on these different things in terms of how they've interacted with their nurse or their midwife. What's the plan going forward, or the strategy to start to equalize that?
Well, there are a number of strategies and plans, and it's really BCCNM working with health system partners as well. So the one reason I really like BCCNM is it is such a collaborator. We can't do all this work in isolation, even though health regulation is kind of a cornerstone or a linchpin to the health system. We have to work with partners. But in BC, there was a report a couple years ago called In Plain Sight, really documenting Indigenous-specific racism in the health system, and with some clear recommendations as well. And so we're diligently going through those recommendations. But one is we're looking at a new complaints process, and it's or an alternative. So there's what we have, but also are there alternatives? And is complaint even the right word? Like, you're just coming in as a complainer where someone, you could have received significant harm. So talking about reports, talking about options of having more of like a learning circle or, arm circle, we now have people trained to support the public throughout this quite bureaucratic and lengthy process. So especially to support Indigenous people coming forward with reports of harm. And then, so we are mandated by law. The BC College of Nurses and Midwives is mandated by law through the Health Professions Act, as all health professions are. BC is in the process of changing that act to the Health Professions and Occupations Act. And so depending on what happens, it could be enacted in 2025. And this act is much more explicit with regards to anti-discrimination measures by health professionals specific to Indigenous people. And it's actually the first act that has ever been aligned with the UN Declaration Rights of Indigenous People or the Declaration Rights of Indigenous People. So there are a lot of changes happening, and BCCNM is considered a leader in the forefront of these changes, which is really why I stay interested in it.
And how does that, assuming the act comes in and replaces the previous document, what would actually be different for the practical applications of day to day of, how the college operates, or, how healthcare providers themselves might have to actually alter their practice?
That's a good question. There's still a lot of unknowns. It's also the biggest act ever.
There's a lot in there.
There's a lot in it. And, it's how it gets laid out. There are some main differences. One is that currently the professional board members, so we have 10 board members, currently they are elected. And so within the Health Professions Act, the Health Professions and Occupations Act, that would be appointed through the government. And so there is question whether that, has political connotations to it. What we understand is that, to do good governance, you need the right people, and the right people really taking the public safety and public interest versus, professional advocacy. And also it's the mix. So we have already quite a strong matrices of kind of the skills and experience and so on that we're looking at the board level. So that's a big change that will likely come forward. Appointing a totally different superintendent of health professions and occupations oversight. It's similar to the Professional Standards Association in the UK. That they were actually reviewed BC and gave some recommendations with regards to this act. So there's questions about how that would actually look like. It's basically regulating the regulators. I think, we choose to take a very positive stance on all of it. Consistency is important. So if someone, goes and complains to the nurses, the physicians, and allied health about one case, which is often like we're team-based care, like often, how can there be a consistent approach? How can there be kind of a unified approach so someone doesn't have to navigate 3 different health regulatory colleges? Like these are all questions that remain that have not been answered, but we will see how it goes. It's going to be a lot of extra work for the colleges. And so, recognizing, trying to figure out how it will actually happen in practice, and the discriminatory terminology in it is significant. So extra processes and so.
And then you raise a good point of how does the regulator get regulated? Is there a complaints process, or maybe complaints isn't the right word, as you pointed out earlier? It's got a bit of a derogatory connotation into it, but how does the regulator get regulated?
Poorly so far. So I think there are steps forward in just giving feedback, and really, I think probably early 2000s or 90s, thank God I wasn't working back then, but, health colleges and professional associations were entwined for a long time. So it's just now that they're being separated. And so there is a lot of learning and growing process with that. And so, it's taken me a long time to really understand what the role of the college is and what my role is as a professional on the board. And it's definitely not to advocate for my profession. And so, it can take a while to figure that out, and people need regular feedback and kind of examples of when kind of the line is crossed, I think.
It is still sort of an evolving field, right? Because in healthcare, self-regulated professions, it's not up to the government to set the standards and the bar and, the professionalism and, just the actual patient care and all these pieces. And so that's the other side of that coin, is it needs to come from within. And kind of teasing apart the two components, right? The advocacy of the people that are, trying to fight for the profession and try and, get change enacted and all these different pieces versus, the people on the inside that are trying to keep the system running and become a well-oiled machine. And so you have to have that separation of the church and the state. Otherwise, it's this very conflicting position to be in.
Yeah, and it's changing and evolving. Like even self-regulation, that terminology is changing to professional regulation, and understanding like we need professionals to regulate. It can't all be, and the government, they they're trying their very best, but that's not their job in terms of health regulation either. So, just trying to figure out also with the professional association, but the Ministry of Health and the governmental side, and kind of sitting in the middle between that. I enjoy it. It's not for everyone. And there are lots of changes happening in the future, I'd say too. But there's no university, there's no programs for regulation, and especially health regulation, which is different than regulating like environmental standards or widgets or something like that, where it's like clearly technical and numbers. Like we are regulating professionals who happen to be human, who are, humans can be challenged to deal with sometimes.
And so a big part of it is the complaints. That's a component of the regulation. What about the education side of things? How do you actually, or what are the requirements, I guess, for?
So it's actually fairly limited in the Act itself in terms of what the college's role is for education, other than we just basically acknowledge or recognize the programs. And so we do review the programs and make sure they're teaching to the standards, make sure that they're following the curricula. And it was an eye-opener for me going on the BC College of Nurses and Midwives, because I think there's hundreds of programs, sometimes with public universities and sometimes private colleges, especially with the LPN programs. And it can be there's varying levels of ability to really determine whether or not they're meeting the standards. And we have varying levels we have limited authority basically to say you need to step up, other than we're going to take your recognition away, which is a fairly hard-handed approach. So yeah, it gets tricky, but it's more just setting the standards and making sure that the education program is teaching the standards and the professional competencies ongoing.
Well, it's a very important job to play. It definitely comes into practice every once in a while. My wife is a nurse, and she said there was actually this really big kerfuffle in Edmonton a few years back. There was a nursing college or nursing school. I can't remember the name of the institution, but they had kind of pulled the wool over everyone's eyes for several years for students going through that thought they were going to be credentialed and licensed to become nurses, but it wound up just being sort of that they were unlicensed, uncertified. And so all these poor people wound up spending several years of their lives getting this kind of dead end credential that wasn't recognized.
Yeah, and there are ethics to that in terms of recruiting people to be able to do that. So sometimes there's active recruiters. And then, for BCCNM, another major strategic focus is the internationally educated nurses. And because we all know that we do need more health professionals in Canada, although Canada is considered a taker of health professionals from other countries who likely need it more. So we're on the bad list for the WHO. So we do have to, think about the ethics while we're doing this. But it previously was an incredibly lengthy process to review overseas educational history, to review employment history and so on from, all sorts of countries, and then to determine their capacity and competency based on that. And it's very open to fraud, especially now as the technology increases. So BCCNM started a new process of actually just determining the competencies in the here and now by basically an OSCE situation. So they come in person and you assess them directly, and you can assess them, of course, the clinical skills, but also the professional skills, the soft skills. In Canada, in BC now, we do have standards on Indigenous-Specific anti-racism. That was the first thing that came out of the In Plain Sight report. And, that's in collaboration with the physicians. And so, do they understand those standards? Like we can assess in real time, and then they can be placed in 3 different designations. They could be placed in the care aide or the LPN or the RN based on that assessment. And and determine extra educational needs to go up. So there's a lot. It's really exciting. There's a lot of changes happening within BC and other parts of the country that are looking at a different competency-based approach to determine internationally educated nurses. And actually, there was a grant from, I think, the federal government, about $10 million to figure out how to do that virtually. And so rather than getting them to come into Canada to do the assessment, can we figure out a way to do this virtually? Yeah, education has a lot to do with also, the ongoing education or recognizing deficiencies for our international educated nurses, and how can we bring them up to a higher standard.
Well, it's really interesting, like just the premise of the ethics behind it at the same time. You make a really good point there of, there's probably a lot of conflict zones where there's nurses and people trying to just, get out of there. But it definitely would be unethical to start removing all the healthcare resources from one of these areas. How do you, I don't know, is there like a reference, or how do people actually go about trying to stay on the good side of ethics when it comes to their international recruitment efforts?
I don't think Canada doesn't have like a clear framework for that, and everyone does it differently. Like even Interior Health, the health authority in where I am based, has their own recruiters internationally, mostly for physicians, but likely so everyone's doing it themselves. And so that's where it can get unethical versus like having more of a framework. My mother's from Trinidad and Tobago, and they're actively recruiting all the time. They come in with lots of promises of excellent jobs, of housing, of immigration, speediness that they usually can't fulfill. But regardless, Trinidad and Tobago has lost a significant number of their health professionals in the last 5 years, and it has a significant impact on the population health that it's served.
And then how do you think they're going to go about that with the grant funding? Is everybody going to be sending out VR devices and it transports you into a virtual delivery room and see how it goes using your Oculus Quest or Valve Index? How do you actually realistically start doing that?
I don't know, but there's people a lot smarter than me that have ideas in terms of what it's going to look like. I think it's out to Tanya right now. So there's a number of people who are providing some different options. It started with BCCNM, but it's actually kind of its own entity now. It's called Inspire Global. And so because that's not really BCCNM's job. Like we're trying to stay core focused. And so of course we want like skilled, competent people within the health system, but it's not really our job to figure that out, thank goodness. And so there's a great group of people who are, but I think, like it's not very glamorous. Health regulation isn't glamorous like AI or like fancy tech or scientific discoveries, but it is the base for a lot of what everyone does in the health professions. But this is actually quite interesting, really trying to like break some barriers and boundaries in terms of how to assess competency.
It was very much needed, right, in order to actually keep the system running, right? Like there's going to be people that get upset and toes that get stepped on, but just like the world needs criminal defense lawyers, defending people that are probably guilty, right? Without these processes and these frameworks and these organizations in place, like the whole thing starts to fall apart and loses its meaning.
Yeah, and we have to think, 5 years, 10 years down the road, because healthcare is just changing quite significantly. So even how to regulate teams, nurses and midwives always work as part of teams, or usually, but it's getting more and more so. Like where are the lines with health regulation? Now we're regulating the individual, right? And usually it's the system or the health authority or something that needs to step up to really kind of look at team-based care and what that means in terms of, meeting standards and quality of care. But, who knows in the future what that's going to look like.
What direction do things seem to be going currently? Team-based care is, all the rage right now. That's probably the number one buzzword in at least the medical world, where I've got my blinders on from. How does the college see that role in terms of regulating within a team?
Well, we recognize that, historically and currently, nurses and midwives have always worked as part of a team, and that, they will continue to work as part of a team. So how that actually looks in the future, how to regulate teams, it's not part of our mandate or authority. Ours is very specifically the individual registrant or professional, and even like health systems in general. Like as we know, there are many gaps and challenges within the health system. But that's actually not our role and responsibility to kind of regulate the faults of the health system or to hold people accountable to stuff that wasn't really there, that they didn't have any power or control over. So yeah, I don't know. I work in a team-based practice, and we've been doing it since before team-based care was even, a buzzword. It's very much shared liability. It's very much shared care. We do 24-hour call cycles and transfer over. So for us, it's just a huge amount of trust within the team, whether that gets moved to a more professional or like formal process in terms of evaluating that. Hard to say.
What kind of people do they choose to be part of the college and part of the board? What kind of personalities are they looking for? I would assume there's definitely some diversity of perspective. Are there any kind of common denominators?
Well, just like any professional board, we're looking for, diversity in lived experience, but also, like financial and accounting and human resources and law and legal. And then, often if we can get rural and urban and just a big mix so we can make good decisions together as a board. And which is basically what good governance is, the right people making good decisions. And so we're even rethinking our whole governance process. We're decolonizing our process. I don't love that term because, we're trying to take what's good from our process, and we're mandated by law, like it's an inherently colonial process, but take what's good. Like we don't use Robert's rules anymore, anything like that. We have a knowledge keeper throughout our whole board. We open in a good manner, we close in a good manner within the Indigenous governance too. So, just trying to find ways that we can really blend in different worldviews, different ways of working and governing together. So, part of my reason why I'm here is to encourage other people to get involved in health regulation, because it does get a bad reputation as kind of like of the health system, but it's actually really interesting work. It's really dynamic. BCCNM is very nimble. It moves quite quickly in terms of health system standards, in terms of addressing needs and cases, which I love being a part of. And so I think everyone could be part of health regulation. And if you're interested, you should try or contact me.
I ran into a lovely fellow at the Canadian Conference on Physician Leadership who worked for the College of Physicians and Surgeons of Alberta. And he was telling me a bit about his story just in terms of transitioning more from clinical to the administrative side. And he had nothing but great things to say about it. He was thoroughly enjoying his time and, kind of the new role of keeping things running smoothly.
Yeah, I think it's great. It's exciting. And we need capable people everywhere. So if you're looking at changing, or I like having both, like I still love my clinical work and I like being involved in health system issues as well.
You said something a minute ago. What were the Roberts rules, I guess, just in terms of the decolonizing the college's process? What did that actually refer to?
Oh, that's just a governance process when you're like in a boardroom or other rooms that you have like different motions, and then you need a second motion and you need a motioner, and there's like all these processes. It actually came out of the Civil War in the military, just to like calm people down and have some order. which can be helpful. But for us, like, when do we actually need emotion? We need emotion for certain things, but we don't need emotion for everything. We don't need a seconder. Like, we're trying to have a discussion and come to a basic consensus here. But it's basically the generative discussion is also just as useful as I motion this and I want to addendum this and like we're trying to have a more relational approach in our work, including at the board level.
So it's just a little too formal, I guess, with some of those more old school things about it. Like whenever we have our board meeting, we need to, formally call it into order and all these different pieces where it's like you don't really get these as part of normal human conversation anywhere else.
Yeah, and do we really need that, like, call to order? We're starting the meeting. Like, sometimes
the whole thing doesn't count. We forgot to call it to order.
Sometimes it's important to have that extra formality, and sometimes it's not. And at the board level, when we're really trying to become a cohesive group only 4 or 5 times a year, like, that formality can actually separate people, whereas we're trying to bring people together.
It was good to see that you guys are like really thinking about these different processes and how can we modernize and update, I guess, just with culture itself.
Yeah, I think about it all the time. Sometimes. Yeah, I'm kind of boring that way, but it doesn't always work. It's not perfect, I have to say.
Awesome. Well, I guess before we wrap up here, final question, ask everyone this one at the end of the show. What is your number one health and wellness tip? How do you keep yourself going?
Oh, health and wellness. Well, I live in the Kootenays, so I have the outdoors easily available to me. But I generally, like, if I go away for a work trip, I try to add some fun in, either a concert or, a really nice dinner, and just trying to find the balance that way as well.
Tanya Mamtazian, thank you so much for joining us today. I really appreciate it.
Thank you so much for having me. Take care.
Thank you for joining us this week on Leaders in Healthcare. If you enjoyed this episode, please like, subscribe, or leave a comment. And if you found this episode helpful, don't forget to share it with your network.